disorders described in DSM, so I'm always happy to see other disorders talked about. And at this meeting, we've already had several talks about ASPD, and that's been something that I've been interested in for a long time, over 30 years as a matter of fact. By the way, this is where I practice. I'm a psychiatrist on the faculty at the University of Iowa. I am an inpatient attending. I see lots of patients over the course of the year. The unit I'm assigned to, maybe 10% of the patients are antisocial. They're probably considered mild antisocials. I have been a consultant with the Iowa prison system for 15 years. I just gave that up because I thought they weren't utilizing me properly. But it gave me a lot of knowledge about the correctional system. Just some disclosures. I do have this book, Bad Boys, Bad Men, Oxford Press, revised and updated in 2013. Updating a book like this isn't that hard because not that much is published about ASPD. But this contains my views, research, and it's really written for the general public, so it includes a lot of interesting cases from the newspapers. And I'm going to skip this because we've had several presentations that review the criteria, just to say that there were no changes from DSM-4 to DSM-5, but I assume all of you know that. But I always give this briefer definition. This is from Goodwin and Gouze, a pattern of recurrent antisocial, delinquent, or criminal behavior that starts in childhood or early adolescence and is manifested by disturbances in many areas of life: family relations, schooling, work, military service, and marriage. So it affects all major life domains. That's how you have to think about it. But I want to ask you some questions. So how come ASPD is virtually ignored by mental health professionals, researchers, and funding agencies? So I come to this meeting, very few talks on ASPD, despite its public health significance. I go to the American Psychiatric Association meeting. Usually there are 0 talks, and this is a 5-day meeting with multiple symposia going on at the same time. They never discuss anything. So just a few days ago, I went to the NIH Reporter website. 0 projects came up when antisocial personality was entered as the keyword. 4 projects had antisocial in the title. 2 had conduct in the title. 2 had psychopath or psychopathy in the title. So you can see that this is under-researched, underfunded. And just in 2012, when I was updating my book, I did the same thing. And 79 projects came up with antisocial personality in the title. So why the difference? Why is there less interest now than even 6 years ago? I don't understand this. Maybe some of you can explain it to me. And it's not because it's uncommon. It's very common. 8.5 million Americans probably meet criteria for ASPD. It occurs worldwide, high rates in prisons, hospitals, clinics like where I work, and among special populations. So if you examine homeless persons, addicts, problem gamblers, you're going to find high rates of this. And I think most of you probably know the risk factors: male gender, low income, low education levels, younger age rather than older age, urban residents rather than rural residents. Well, one of the things I point out to my residents, I'm also the training director in my department, so I give talks on BPD, ASPD, the psychopharmacology of personality disorders, and so on. But I point out to them that the mean IQ of antisocials is below average. So most of these patients I see are not very smart. Most of them are kind of dumb, low IQs, very poor education levels. So the myth is this Cleckley psychopathy myth that they're superficially charming, they're intelligent, and so on. That describes a minority of people with these disorders. Comorbidity is the rule. Substance use disorders, mood disorders, anxiety disorders, ADHD, gambling disorder. Now, I'll just make a comment about the overlap with ADHD. So on my unit, I have a lot of problem with these patients because they'll say, you need to give me a stimulant medication for my ADHD. And I say, I'm not going to do it. You're an addict. You've been addicted. Well, where did you get that information? Someone challenged me a few months. Where did you get? I said, it's in your chart, your medical chart. I can show it to you. So he stopped asking. Excess morbidity and mortality. I think now what I've highlighted in red is probably the most important thing here. It's a predictor of poor treatment response in general. If you're an addict and you're in a substance abuse program, you're not going to respond as well. If you're depressed and someone gives you an antidepressant, you're not going to respond as well, and so on. So you know the conduct disorder precedes the onset of ASPD. The trajectory starts very early, usually before age 8. 80% of future cases have developed their first symptoms by age 11, boys earlier than girls. 25% of girls with conduct disorder, 40% of boys with conduct disorder go on to meet ASPD criteria. It's chronic for most. Lee Robbins did a follow-up study. I did a follow-up study. We found very similar results. Hers was longer than mine, so in her case, 61% were unimproved or worse after 30 years, where I found 42% unimproved or worse. Now, I do describe these in great detail in that book that I mentioned. So this is what I wrote in 1995 when I published my main results. So while most subjects were no longer having frequent confrontations, so this was after a 30-year follow-up on average, they were no longer having frequent confrontations with the police. They continued to have enduring problems with poor occupational performance, social isolation, marital discord, poor family relations, and substance abuse. Yet over 90% of those interviewed reported that they had settled down. And I'm going to skip that because we don't have time. And I'm not going to say much about etiology because I don't have the time to do that, other than to say we don't know what causes this, but people have pointed to early childhood maltreatment, high heritability. It does run in family. Estimates of heritability are 0.81, and then disturbed neurocircuitry in the brain. But this is a clinical update. I assume most of you are clinicians in some sense. I see a few psychiatrists in the audience who prescribe medication, so I want to tell you about this. There are no FDA-approved medications. I assume you know that. Say any medication I or some other doctor prescribes is off-label. No medication is routinely used. Some drugs can reduce aggression, but have not specifically been looked at in ASPD. So occasional antisocials will come on the unit and say, you need to give me something for my anger. They don't really identify with the diagnosis of ASPD, but they will acknowledge anger, impulsivity, and so on. And some are willing to take medications. But medication is not an answer because most of these people will not come to clinics, will not acknowledge that they have a disorder, and in fact they'll say, you have the problem, doctor, not me. I've been told that. So you should target the comorbid disorders. Say, okay, you have a depressive disorder and I can treat that with an SSRI. You have panic disorder, so I'll treat that. You have ADHD, I'm not going to give you a stimulant, but we have non-stimulant treatments. You need to avoid stimulants and benzodiazepines because they are addicting and they're often abused by these people. The benzos might be disinhibiting as well. We have no good literature on this, but if you think about the properties of these medications. So let me talk about psychotherapy. Now, I was very intrigued by Anthony Bateman's talk, but there are no data. And the fact that he now has a grant to explore that in the UK, that's great, because no one studies this in the United States. I can assure you of that. So CBT has been studied and may be appropriate for mild cases, but evidence is limited. So Davidson published an RCT that was negative, although if you read her paper, she describes some subjects having appeared to benefit. Antisocials may benefit from treatment for drug or alcohol addiction. ASPD is always worse in people who are actively abusing. Some antisocials may benefit from specific programs, a program for batterers. There's one in Iowa called the Iowa Batterers Program, and people are usually sentenced to go through that program, for spousal abuse, things like that. There are criminal thinking programs in prison settings that may help, anger management. So a lot of these people, I'll say, you need anger management. Well, what do I do? Well, we have groups in our clinic. You can go to the Barnes & Noble, to the psychology section. There are dozens of books on anger management. Some of them have very useful advice. Antisocials tend not to read much, though. So, guidelines, what do they say? The NICE Institute, medication should not be routinely used. Psychotherapy, evidence limited to one trial. CBT may not be cost-saving in the short run. Cochrane reviews medication, the body of evidence is insufficient to allow any conclusion. Psychotherapy, no study reported significant change for any specific antisocial behavior. So this is not a good situation. But then I told you, NIH is not interested in funding studies. So new clinical advances. So I did publish a paper recently. Anthony Bateman published a paper recently, and they're both kind of similar. So what I did is I looked at people who attended our STEPS program at Iowa for borderline PD who had comorbid ASPD. And I had two samples, a university sample and a prison sample. They showed the identical thing. So comorbid ASPD did not interfere with improvement from STEPS. And those with comorbid ASPD experienced greater benefit from STEPS than those without. Now, we weren't treating the ASPD, we were treating BPD. And that's essentially what Tony Bateman showed. So BPD plus comorbid ASPD assigned to MBT versus structured clinical management, both groups improved. And this is from my study showing that, so comparing BPD alone cases to BPD plus ASPD, the combined cases are in red, and you can see that the lines are essentially parallel. So conclusions, it's common, it's widespread, it's chronic and lifelong for most. Most persons with ASPD symptomatically improve with advancing age. So maybe when they're older, they no longer fulfill ASPD criteria. That doesn't mean they're remarkably well, though. And that's true with BPD if you read Zanarini's follow-up studies. Etiology is likely multifactorial. Treatment is challenging and should probably be focused on the comorbid disorders. So that's pretty much all I can tell you in 15 minutes. And we'll go on to the next talk. So let's see.